Hello everyone, welcome to another episode of Ultrasound Podcast, where we dive deep into the cutting-edge practices and game-changing innovations in the point-of-care ultrasound. Today, we have an extraordinary guest joining us. He is none other than Dr. Adrian Goudie. Adrian has an illustrious career in emergency medicine with a very special interest in ultrasound. He is a specialist in emergency medicine at one of the busiest hospitals in Perth, Western Australia. Adrian is not just a leader in his field. He is a trailblazer with a passion for pushing the boundaries of what is possible in emergency medicine. Adrian has been at the forefront of integrating advanced ultrasound techniques right into the heart of emergency medicine. I am truly thrilled to have Adrian in the podcast today. So without further ado, please join me in welcoming the one and only Dr. Adrian Goudie. Hi, Adrian. Thanks for joining us. Ultrasound in advanced life support. This is such an interesting topic, and this is probably one of those most used technique in the emergency department in those time-critical, life-threatening emergencies, cardiac arrest, peri-arrest scenarios. So I thought that we'll talk about it a little bit. So we have already talked about a few of these topics. There are a lot of myths about the use of ultrasound in advanced life support, but the reality is a little different. And these myths not only applies for advanced life support, but also in some of the general ultrasound. Let's focus on those one at a time,
Okay.
Adrian.
Yes.
So one of the myths that I hear from many of our colleagues, especially who are not using ultrasound that often for advanced life support, is that the ultrasound is only for the experts. What is your take on it?
Look, I think ultrasound, like many other things, the more you learn, the more useful it will be. But even if you don't know very much, there are some things that with ultrasound ultrasound is very good at answering some clinical questions that are otherwise really, really difficult to answer. But with ultrasound, it's quite easy. And the sorts of things that I use as examples of this are, is there an abdominal aortic aneurysm? You know, that's really hard. I mean, you probably remember being taught as a medical student, you're supposed to bring your fingers in from the side. If the pulsation goes that way, it's a
That's
transmitted
right.
pulse. If it goes that way, it's an aneurysm.
Exactly.
Really? Whereas most of the time you can put a probe on and you go, there it is. It doesn't take much training to be able to see a big pulsating aorta and go, that's an aneurysm. The other thing is tamponade. I mean, to clinically diagnose tamponade with confidence is really, really difficult. You know, pulsus paradoxus, poor perfusion, muffled heart sounds. You know, I mean, I'm kidding myself if I think I can do that accurately. But with echo, even just a single subcostal view, again, it's one of the simplest things that you can learn how to do with an echo probe. And yet it answers a question that is really, really difficult otherwise. So what I say to people is, look, when you're starting off, when you're trying to learn, pick these things that are technically easy to do with an ultrasound, but answer questions that are clinically really, really difficult. So the tamponade, the AAA, is the pregnancy intrauterine or not? You know, when people talk about, you do a pelvic exam and you try and feel whether there's a pelvic mass to diagnose an ectopic. And I just think, hey, maybe if you're a senior gynecologist, you can do that. But for all the rest of us, no way. Give me an ultrasound probe instead. Not because I'm going to diagnose the ectopic, because that takes a bit more skill, but because if I put the probe on and I see a uterus, and inside that uterus I clearly see a gestational sac with an embryo, the heartbeat, which makes it easier to see, then I can go, yeah, all right. If I did see that and no free fluid, I've pretty much diagnosed no ectopic, you know. And yes, there's the really rare edge case, heterotopic pregnancies, all these things. But these are really simple things to use from an ultrasound perspective. You know, you don't need to have 5 years of training as a sonographer to answer those questions. You learn those things pretty quick, and yet they answer the questions that we really struggle with otherwise.
Excellent. Thank you. So you don't need to be expert. It needs some training. It needs some supervision and lots of practice.
Yep.
And if we can practice in the stable patients, in case of cardiac arrest, that becomes super useful.
Yep. Yes, agreed completely.
The second myth that I hear from many of the colleagues is ultrasound is time consuming, and some of the colleagues actually say that you are wasting time, see some patients. What is your take about it?
Look, I think when you start, you're going to be slow. Ultrasound is going to be a bit time consuming when you start. But I think that you very rapidly, the learning curve is quite steep and you will get quicker very rapidly. And so, you know, certainly for me, and I do a lot of ultrasound, I've been doing it a long while. It's quicker for me to do an ultrasound to answer the question than to try and do all the other things often. I can often do an ultrasound whilst I'm talking to the patient. And so that combined time of history and ultrasound is really not much more than just the history. And because I'm doing the ultrasound, I might be able to curtail some of that history and particularly the examination. And I think also from the department's point of view, it's often, and I hear this argument and I understand this argument, but I think it underplays how much the patient flow can be improved by doing ultrasound. Because, you know, for example, if somebody says to me often, oh, I've got a patient there, I think they might have a DVT. Now, yes, I can take a history, I can examine them, I can take a blood test, I can do their pretest probability, I can send off a D-dimer, I can get the result, and then I can decide whether or not they need further investigation. But to be honest, most of the time I'll look at them and I'll go, just jump up on the bed, I'm going to do a scan. And, you know, so long as they haven't got huge, massive legs and they're technically very difficult, you know, it might take me 10 minutes to do that. And at the end of the 10 minutes, I can say, you don't have a deep vein thrombosis in that leg, you can go home. Or I'll say, you do, and I'm going to do whatever I need to do with them. But if you want me to clear that cubicle quickly, I'm just going to go in and do the ultrasound, because not only is that quicker for me, it's much quicker for the whole department and for the hospital and for the patient as well. But yeah, that takes a little bit of time and practice. So as I said in the answer to the last question, I think you've got to be a bit selective when you start. Don't start with the thing that's going to take you an hour when the department's falling apart and horribly busy, and you're going to get an answer that you're not going to be confident of because it's a technically really difficult scan. Start with the thing that's going to be quick and easy, because the patient you don't have to send for an abdo CT as query AAA. That's just saved a lot of time for everybody. Now you might say, oh, well, if they're going for a CT abdomen anyway, well, that's a different matter. But, you know, they come in and they go, oh, look, this patient, I think they've just sprained their, you know, they've got a back sprain, or they've strained it because they hurt it while they were gardening. But I'm a bit worried about maybe it's a AAA because maybe there's a bit of a pulsation. Now, you know, you either take a gamble and don't do any imaging, or if you don't do ultrasound, you've got to then try and persuade the radiologist to do a CT, that they think, well, it's probably going to be normal, and it probably will be. You've got this whole train of things that are going to happen that's going to block up your whole department. Or you can push the ultrasound in, and if they're a thin elderly person, and then you say, yep, that's it, that's sorted. I don't have to do all those other things. So you've got to pick your patient, you've got to pick your scan, but if you do it right, ultrasound saves time overall. And as you get a bit more experience, the range of things that happens for gets ever increasing.
Excellent. Thanks for clarifying that myth. And another myth that I can hear, or that is the perception of some of the clinicians, is that ultrasound can replace the physical examination. What is your take, Adrian?
Look, I think ultrasound doesn't replace physical examination. I often combine ultrasound with physical examination because I know where it's going to be sore, but instead of pressing with my hand, I press with the ultrasound probe. I think in some ways, I think of physical exam, I try and approach it the same way as I do ultrasound or any other investigation. I need it to answer a question for me. Does this patient have whatever? Do they have an abdominal aneurysm? Have they, ruptured their papillary muscle and now they're in, they've gone into crashing pulmonary edema? Now, there are some things that physical exam is really good for. If you look at, say, the HINTS test, if done properly and you're experienced, then that's better than an MRI.
Exactly.
For diagnosing strokes. Mm-hmm. But there are some things physical exam is hopeless for, such as, does this patient have a lot of free fluid in the abdomen? Now, okay, if they've got massive ascites, it's easy. But, the trauma patient, do they have free fluid? The query ruptured ectopic, physical exam for that is terrible. So I would say, as a complete statement, that is wrong. Ultrasound cannot replace physical exam. But what I would say is ultrasound can answer some questions that physical exam cannot. But yes, you don't replace physical exam. And physical exam, in general, it's rapid and it's cheap and it has minimal side effects. So it should still be, after the history, our starting point to then create all our pre-test probability that we then go the next step for whatever investigations.
Thank you. So ultrasound can actually be an adjunct to the physical examination.
Absolutely, yes.
Thank you. There is a myth that ultrasound is invasive. What is your take on it, Adrian?
As a general statement, no. There are some forms of ultrasound that are invasive to different extents, like transesophageal, transvaginal. And you can actually also do intravascular ultrasound. We don't do it, but some of the vascular surgeons and some of the cardiologists do. Mm-hmm. But, when we routinely talk about ultrasound, no, it's not invasive. Now, it has a very, very good safety profile. We do have to bear in mind that there are bioeffects from ultrasound, so there are certain things we need to be a bit cautious about. We need to be cautious when we're doing ocular ultrasound that we use low energy, so because we don't want to heat the eye. We need to be careful when we're inseminating early pregnancy, particularly in that very small embryo phase, because we don't want to cause any heating of the embryo. We also don't want to excessively insunate the lung and put high power through the lung, because we know we can actually cause pulmonary hemorrhage if we use high ultrasound power. So, everything has pluses and minuses, risks and benefits. We need to know them. We need to minimize the harms that we cause. But overall, I'd say no, ultrasound is not invasive, and more importantly, it's a very safe modality.
Excellent, thank you. There is another misunderstanding or misconception, or myth rather, that ultrasound is only for cardiac arrest. How do you feel about that? What is your take, Adrian?
Well, I mean, most of the ultrasound I do is not for cardiac arrest. That's a very small part of what I use ultrasound for. Even if we're talking about the basic echo, I would still say most of the time you're not going to be using it for cardiac arrest. And if at all possible, try and use it before they get to cardiac arrest. Now, sometimes we don't have that option, but I'd very strongly recommend, like everything we do, don't wait for the patient to arrest. Try and get in there before and prevent the cardiac arrest.
Ultrasound image quality, that's a big topic, especially in case of the young trainees. They feel a bit lack of confidence that they are not getting the best picture, especially in case of the cardiac arrest scenarios. What is your take on this myth, Adrian?
Yeah, I mean, the ultrasound image quality needs to be good enough for you to confidently answer the question that you're asking. And depending on what that question is, it's going to depend on what level of quality you need, which is why, for example, if people say to me, should I be trying to measure the aortic valve gradients? I'd go, no, not until you have a lot of experience, not until you can get images of very high quality. Because if you want to answer that question accurately, you need to be able to have very high quality images. On the other hand, what level of quality do you need to get to answer the question, is there a big pericardial effusion? Well, fortunately, you don't need very high quality at all to answer that question.
Mm-hmm.
So, as I said, perfect, we work in emergency. We might aim for perfect, but we very, very rarely get there. It's got to be good enough to answer the question, and you need to know how good it has to be for your question. And don't try and use it for things where you need much higher quality to answer those questions.
Excellent. Thank you for sharing that. One of the myths is that ultrasound in advanced life support is not evidence-based, and we have talked about it. Please tell us a little bit more about this myth.
Well, I mean, I would say the evidence is weak. And so in that sense, you might say, well, it isn't evidence-based. But I would also say, well, most of what we do in ALS is not evidence-based. We'd like it to be, and slowly the evidence base is improving. But a lot of what we do is not evidence-based. We've got to make the best of what evidence we have. There is some evidence for ultrasound in ALS. It's not great quality. I certainly advocate for let's get some better quality to improve the evidence base. But I think it's a little harsh saying that there's no evidence base. And I'd also point out that there's an awful lot of other stuff in ALS that is at that same category as well.
Excellent. Thank you for that. What is the implication of this ultrasound use in ALS for the emergency department, Adrian?
Well, I think that the main implication is for training. As I mentioned, I think most places now have the equipment. What we need is the training for everybody to be well practiced in this, to be able to do it without causing breaks in CPR, and for the whole team to understand how this is performed and how it works and how to do it without causing any adverse effects.
Excellent. Thank you very much. So we are nearly at the end of this talk, Adrian. What will be your main tips and tricks or advice to the clinicians who are using the ultrasound in advanced life support or are training or getting involved in this process of learning this?
I mean, I think as I've said, and I'm probably starting to sound a bit like a broken record here, my main advice for people is just practice. Even if I know it's hard to start with, and I know you're really busy, but it will pay off. I promise. So get some practice, just keep trying to do it, little bit, and then you'll find suddenly you're going to be getting better images much faster, and you're going to start getting really useful information. And then you're going to have a case and you think, wow, if I hadn't used ultrasound, I would have been totally sunk there. So that's my main advice. In terms of specific tips and tricks, I mean, those are the things that I've mentioned before. Don't just use the subcostal window. Don't just look during the pulse check. And make sure your team is all practiced and you know how to do this without interrupting the overall flow of the advanced life support algorithm. And don't extend the breaks in CPR.
Excellent. Thank you for those gold nuggets for sharing with us. There are quite a few articles on this topic, and the main topic that we focused on is the recent paper that was published in Diagnostics. And also there are quite a few papers which talk about this use of ultrasound, the debates, the usefulness, or they are controversial. Once again, Adrian, it was a great privilege having you here, and thanks for sharing with us all your thoughts, all your expertise, and those beautiful clips from your collection. I'm really fascinated by seeing the use of ultrasound in advanced life support.
All right. Well, thank you very much. I mean, it's been a real pleasure to talk to you and for you to listen to me talk and talk and talk. Thank you very much, and I hope people have gained something from it. And yeah, very happy to answer any questions that people have if they want to drop me a line. Otherwise, we'll probably see you around somewhere in one of the conferences somewhere.
Thank you very much, and I hope that we'll see you again. Thank you, Adrian. Okay.
Bye then.
Now.
Thank you.